If you're feeling frustrated by the weight gain that seems to come hand in hand with menopause, you're in the right place. Today in the Menowave Lounge, we're tackling one of the hottest topics out there, the buzz around injectable weight loss medications like Ozempic, Mounjaro, and Wegovy. Our guest today has the lowdown on how these GLP-1 inhibitors can help manage weight gain during menopause. Plus, we'll dive into why we gain weight in the first place and how hormone replacement therapy can make a difference. Get ready for some eye-opening insights and practical advice that could change your menopause journey. Stay tuned, you won't want to miss this.
Hi, everyone. Welcome to the Menowave Lounge. Hot flashes and cool conversations.
In this episode, we have the pleasure of speaking with Dr. Christine Schiller, a seasoned nurse practitioner with over 25 years of experience in specialized care. Dr. Schiller is passionate about hormone replacement therapy and weight management, particularly for women dealing with hormonal imbalances. And in today's episode, we're going to talk about debunking the myths of HRT, the benefits and concerns of something that we're just all starting to hear more and more about, GLP-1 inhibitors, things like the semaglutide and Ozempic, those type of treatments. And we're going to learn a little bit more about what those are and how helpful they are and the risks and benefits and much more. So I'm really excited to have Christine with us and excited to do the episode today.
Hi, Christine.
Hi,
Welcome
how are
to
you?
the show.
Hi, thanks for inviting me. I appreciate it.
Our pleasure. Before we begin, we always like to start with what we call a Meno moment, which is just a lighthearted, fun perspective look at the unnerving things that sometimes we find ourselves encountering on a day-to-day basis as we go through this stage of life. Robin, you want to start us off?
Well, yes, I will. Of lately, especially today, I've been finding that in conversations, I've been kind of losing my words. Like I'll have a thought process going and then my word will and then I'm just like, okay, what is going on here? Where's my minnow brain going with this? And it's not every day. Sometimes it's just, kind of random, like now. So if I do this during the course of this podcast, please forgive me because the word will come back, the phrase and the direction of my conversation will come back. But it is a minnow moment and I just have to laugh at it because it's not all the time. It's just today.
Christine, how about you?
I mean, I think that I can think of many. I just thought of one because, your mind goes all over the place. Our minds, like open apps all over your computer. But so I have a few dogs and I also babysit my kids' dogs and I call them all honey. They all have names, but I just say, oh, my honey, my honey. And I realized my grandparents did the same thing. And now I realize because they didn't remember our names. So now I realize I do the same thing because it's easier to say my little honey than remember all their names.
I had a funny one that I wanted to share. And actually, I think it was after we recorded last week's podcast episode, but I was dressed up and I went out after socializing and I got home that night and it's like, I'm just put my jammies on. I realized that I'd worn my blouse backwards the entire day. I'm like, what is this? And it's like, hello, it's the tag. I'm like, oh, it was backwards. Again, but yeah, it's just one of those things. I'm like, yep, Meno moment.
Yeah, I can relate to all those moments. And honey, sweetheart, that's what I used to call my kids. Yeah, they always knew. It was like we were having a moment.
It was offensive. I thought that's kind of offensive that they call everybody honey. And now I'm like, no, they're actually being kind because they can't remember your names.
That's funny. Well, Christine, can you tell us a little bit about how you got into your field and a little bit about your background and what led you to specialize in hormone replacement therapy and weight management?
So believe it or not, I started my education. I got an accounting degree and realized I absolutely hated it. And I teach graduate school too. So I told all my students, because I didn't like accounting, I looked in the paper and I said, what kind of job can I get where I only have to work 2 or 3 days a week and I could make good money? And I said, oh, I should be a nurse. So I went to nursing school and I realized that I really liked it. I enjoyed it. I really cared about taking care of people and learning about them. So I actually started my career in pediatrics, taking care of children with chronic illnesses, actually specialized in pediatric oncology. When I decided to go back to school for my master's, I realized I had never actually touched an adult. So I went to the emergency room and I said, I have a pulse and a brain. You think I could work here? And they said, sure. We like people with pulses and brains. So I worked in emergency medicine for several years. And then after my master's degree, I actually took a job in primary care because it worked better with my lifestyle. I had young children. And when I started that primary care practice, I took the position of a woman who only saw women, and she saw a large amount of women. And if you can imagine, when they walked in, they saw me and they were very upset, saying, well, she knows all about me and my health. And I have all these questions. And I said, I promise, I'm going to do my best to try and replace her. I mean, she was like the menopause queen. I said, I'm going to try and be a princess. I'll try very hard. So I realized, seeing all these patients, that they were getting a lot of misinformation. They were getting a lot of pats on the head saying, you're exaggerating, honey, just deal with it. And I just went on a journey with these women that were suffering from hot flashes, mood disorders, insomnia. And I asked a colleague of mine, what should I do with all these women? What do you think I do? How should I treat their symptoms? And she was a female, and she was probably 45. And she said, just give them all Ambien and Lexapro. And I thought, I wouldn't take that. So I didn't like that answer. And I went on a journey with women, and I said, there has to be something out there. So we went through all alternative methods and discovered that HRT was really helpful for women. I had a few patients who said, I'm suffering. I listened to them and I helped them. And then as I got older, and some of my colleagues were males, and I said, I treat a lot of women who can't sleep and they can't lose weight. And this one young male I work with said, well, tell them they just need to eat better and exercise. And I said, all right, well, I'm going to get like 15 of them in here in this room, and I'm going to have you tell them that. And then I'm going to watch them tear you limb from limb, and I'm going to enjoy every single moment of it. So that's where I also, kind of went into, all right, how can we help better lifestyle, better health, and just in general, feeling better about yourself as we go through these next chapters of our life.
Well, that's amazing. And what a big shift for you, and to actually go from an emergency room into working with women in menopause, and then actually educating yourself as to what their needs are, because it's such a wide area of symptoms that we have, and not any one woman has the same as another, and we all have it same but different. So how do you create a personal treatment plan for your patients, knowing that they have such a wide range of symptoms from menopause?
So I really start with a symptom category. I'm very blessed in that the majority of patients get referred to me. So they've already kind of spoken with their friends. And I would say the majority of them come in with a list of their complaints. And I just go through all of it. And I say, well, what is the biggest concern for you today? And we kind of start there and then move on and try to hit all the categories. But I think the number one thing is just that I reaffirm with women that you're not crazy. This is happening to you. I'm sorry that other people made you feel crazy or didn't listen to your concerns, but I'm here. And it's interesting that sometimes even just listening to them, they're like, I feel better. I don't need another appointment. So I think listening is the key component, and then going to the symptoms and making a treatment plan with them.
Christine, why is it, in your opinion, like you mentioned that you were talking to another woman who was 45 and her first thought was, okay, we'll put them on an antidepressant. And then you talked to this other doctor who said like, well, they just need to eat less. They need to eat better. Why is it still today that's still the message that these women get? And then and then the second part of that is, did we ever able to get those 15 women in the room with that man? And is he still alive?
Well, I did bring a few in. I threatened him too, because he said, we were talking about sleep with, I think, a pharmaceutical rep who sold a sleep medication. And he said the same thing about, well, these women don't sleep because they need to exercise before they go to bed. If you can't sleep, it's your body telling you you're not tired. And I said, hold on, I'm going to call a few in. And he was like, oh, I'm so sorry. Please don't do that. But for somebody to be struggling and having someone just dismiss them like that, it to me is not appropriate. When you go to, let's say, your primary care, they like to treat your high blood pressure, your high cholesterol, your type 2 diabetes, your thyroid. Treating hormones is a little bit more detailed and it's more specific to the patient. So they would rather kind of do that all day than really sit down with you and say, How can I help you? What avenue do you want to take? I think that I chose this avenue because I'm not a medication person myself. I'm not saying I'm against medication, but I'm more of a alternative complementary person myself.
Well, and it's so mind-boggling as well, because as we know, as balancing hormones themselves is so unique to each woman. You can exercise and eat calories in, calories out all you want, but if your hormones are completely all over the place, your hormones are awry, you've got a problem with your thyroid over here, that's messing with your hormones over here, your cortisol is too high, and so that's messing with your body's ability to produce estrogen. I'm probably saying this all wrong, but my point is that they're all interconnected, and that's so complicated in and of itself that it is just so disempowering and so frustrating. And then it will even feel horrible. And then that leads to more stress. And then that throws everything else out of balance. And it really feels that women, if we're even aware of the interconnectedness of our hormones, we have to do our own research, which I think every woman should do a little bit and educate herself, but it's so complicated.
Yes, I tell everybody, I feel as a medical person, and I have a doctorate PhD that I went back for. I'm a researcher, and I just think it's important that I've always said, even if I give you an Advil and you say to me, it turned my hair blue, I believe you. So that's one thing, is just working with patients. And, people like to stay in their little niche. I do see it a lot on some of the conversations in Menowave. Women will say, well, I didn't get anywhere with my PCP. I didn't get anywhere with my OBGYN. I'm going to go to an endocrinologist. And then they're just kind of turned away again when the endocrinologist said, well, no, I don't do that. I do thyroid, I do diabetes. So it's disheartening that they keep going to different specialties and can't kind of get any help. Or once again, they're pushed towards, well, maybe you just need an antidepressant. And I'm not saying antidepressants are bad. That's not what I'm saying at all. Antidepressants are great if that's what you need them for, but also there are side effects to antidepressants. If a woman is going through those stages of her life of menopause, and you give her an antidepressant, such as something called an SSRI, which is like the Lexapro, Prozac, Alexa, they're the brand names. Those medications have a tendency to make you gain a little weight. So I always thought, well, they're already mad, they're gaining weight, and I'm going to give them an SSRI, and they're going to, gain me more. I'm like, they're going to tear me limb from limb. So you have to really look at what the person is complaining of and help them deal with those symptoms.
I've seen in the menopause support group, women say, I eat right, I exercise, I've been on top of this my whole life. And all of a sudden, like overnight, all of a sudden my belly I'm getting fat, my upper belly or my lower belly. What is happening there?
So when you go through menopause, you have a depletion of your hormones. So the three major hormones are your estrogen, and there's three actually type of estrogens: estradiol, estriol, estrone. But we'll just say estrone for our purposes. You also lose progesterone. So estrogen is like stepping on a gas pedal. It gives you energy. Estrogen helps with bleeding and all of that. Then you also have progesterone. So progesterone helps with mood. It helps with sleep. And then you also have testosterone. So testosterone, most women don't have a lot of testosterone, but a depletion of testosterone will give you low energy and low libido. So when you have a decrease of estrogen, that leads to inflammation. Inflammation in your body makes it harder to fight things. So a lot of women, they may not have a period for a year. So let's say they go for their yearly physical at 50. They go back at 51 and your blood pressure's up, your labs, your cholesterol is up. And you say, I've never had that in my life. So reduced estrogen leads to more inflammation in your body. So more inflammation, it's harder to fight the cortisol that you mentioned. If you're not sleeping, you have a higher cortisol level. That will give you belly fat. And also, reduced inflammation can contribute to increased adipose tissue. Adipose tissue is the belly fat. So that's where when women say, I didn't do anything different and I gained 10 pounds in a year, it's because we need to balance those hormones.
So it's the inflammation that's caused like the adipose tissue.
Inflammation can do all that. A lot of women will say, especially if you have a job that, we all on a computer, or I was seeing a patient today and she is hairstylist. So she has a lot of inflammation in her joints since she's gone through menopause. She's now on hormone therapy and she's feeling better, but people don't realize that Lack of estrogen will give a lot of women palpitations. And then one thing that happens also in menopause that some of us forget about, we don't sleep as well. So some women have one glass of wine, or I always ask women, how big is your glass of wine? Is it a bottle? Because they don't sleep and they're tired. They really want to sleep. So sometimes they don't even realize that glass of red wine, even though it helps you sleep, it adds to more inflammation. And
yes,
it has
and then it wakes you up later in the day, in the night. It wakes you
yes,
up.
and also they'll go to sleep, but then they'll wake up. So if you don't have good sleep patterns, even if I were to see a man who has a big belly and he's overweight and I'll say to him, well, you have that big belly, you have sleep apnea, and I'll tell him all this, and he'll say, how do you know all that? I'm like, I'm just looking at you because if you don't sleep well, or you have sleep apnea, that will give you more of that belly fat. So you could go from being a really great sleeper to, as you go through menopause, especially as those progesterone levels decrease, from somebody who, wide awake all night. And it's very frustrating.
So how does this all tie in with the HRT?
So HRT stands for hormone replacement therapy. It has multiple different layers. And I'm going to start a long time ago. So a long time ago, even my own mother, I believe she had a hysterectomy in her early 40s. And back then, if you coughed wrong, they took out your uterus. They just took it out. And nowadays, we really try to hold on to the uterus. We really try to do everything we can so you don't have a hysterectomy, because we are aware that your uterus helps support your bladder. So if you take out someone's uterus, you're causing a whole other issue with having urinary incontinence and just leakage, and that's a whole other topic. So we realized, hold on to that uterus. My mother was given Premarin, and actually she's still on it after 40 years.
Now, Premarin that's the one with the horse urine?
Yes, so that's made from horse urine, but it's made in a lab. So people have a bad connotation with that. So Premarin was around initially, and that's what most women were given. And I'll go on a side here, but some women will say to me, my mother never had these problems when she went through menopause. And I'll say, well, your mom probably had a very nice doctor who gave her a bottle of Valium. And they're like, you're right. I said, that's like, mother's happy little pill. So they said, oh, you're crazy and moody. Here's some Valium. So that's when I tell people that, they're like, oh, you're right. That's why. And I tell people, your mom didn't work. Your mom didn't have the same responsibilities. There was a study that was done many years ago. It was called the Women's Health Initiative. In that study, which every study, the three of us could be in a study. We could all walk in one day and they say to me, how are you doing? And I say, you know what? I had a bloody nose. So they put in the study, side effect is a bloody nose. Marty walks in and she said, I had a heart attack last week. And they say, heart attack. But Marty doesn't mention that she's been smoking Marlboros for 20 years. She eats bacon grease and she doesn't exercise. And then Robin comes in and Robin says, well, I had this side effect. So that's one thing people don't realize. So what happened is, during that study called the Women's Health Initiative, which is also a study that was mostly nurses. I don't know if anybody knows a lot of nurses, but working in that community, they always take care of other people and not themselves. So I hate to say this for people who work night shift, but working night shift is very bad for your hormones. It ruins your circadian rhythm, and that upsets everything. So some of those women in the study also developed cardiac issues, some breast issues. So because of that, they said, everybody off your hormones, get off your hormones. So medical providers who went to school during that study always were told hormones are bad, don't prescribe them. Now, fast forward years later, and even myself, I looked at the study and I said, it's not a good study. But then people came up with what's called bioidentical hormone replacement, which is BHRT. So that's more plant-derived. But fast forward now, the Journal of the American Medical Association came out about 3-4 years ago and said that women's study was a terrible study. So now a lot of young providers no, you need hormones, get on hormones. And that's one thing I even tell people. I'll say, you either need to go to a really old doctor or a really young one. Because the middle ones, they're the ones that say, no, it's bad for you, you can't have it. But they haven't taken the time to say, well, let me do my due diligence and do a deeper dive into these studies and see if that's correct. So now that's why you're talking about it more. I mean, you're seeing it on, I think, Oprah Winfrey's on hormone replacements, Maria Shriver. So more and more people are coming into the conversation and saying the same thing is, I had all these issues and I went to the cardiologist, I went to the endocrinologist, I went to the psychiatrist, I went to all these people. And that one person said, your symptoms are of menopause.
Is HRT made up specifically individually for the lady who has different symptoms? Because I understand there's certain tests, but then there are other tests that don't really give true hormone balances. I mean, you have to do a specialized test, and I forget the name of it, Marty. I know you remember it.
The Dutch test?
So there's different types of HRT. Like I said, my mom is on Premarin. That is rarely prescribed anymore. We really tried, as with any medication, if we can eliminate, which is called the first pass effect, is not going through your liver, we try to do that. So with our estrogens, we really try to replace that. And estrogens, I would say one of the biggest things besides inflammation is hot flashes. A lot of women today are in the corporate world and they can't be in a Zoom or in a meeting and just taking off their clothes and sweating, and it gets very upsetting. So estrogen is something that helps with that. The progesterone helps with sleep and mood. Testosterone helps with libido. So estrogens, there's two types, either the pharmaceutical grade or you can get BHRT, which is bioidentical from a place called a compounding pharmacy. Compounding pharmacy, and I always tell people, when you see that old mortal and pestle on a pharmacy, that means they make it there. So compounding pharmacies have actually been around longer than pharmaceutical made drugs. And that's where people kind of get confused and they say, well, it's not regulated. And so a compounding pharmacy actually has to go through more testing with the FDA. They have to buy special equipment to make the compounding pharmacy. So to go back to the different types, if you are a woman, let's say, who's just had a hysterectomy, a lot of times you're just giving estrogen. You only need progesterone theoretically if you don't have a uterus. If you have a uterus and you give somebody estrogen without progesterone, you can make them bleed. The only nice thing about menopause is not bleeding. The last thing I want to do is make somebody bleed. So estrogen can be given in a pill. Like I said, the Premarin, which we kind of stay away from. It can be given in a patch, which a lot of women like. The patch is replaced either weekly or bi-weekly. It can also be given in a cream, which is bioidentical, or it can be pharmaceutical. It can also be given in something called a troche. A troche is a little pill and it's sublingual, meaning you put it in the side of your mouth and it's absorbed that way. It can also be given in something called a pellet. And a pellet is probably less than the size of a Tic Tac. And it's a little procedure that it's placed in your hip and it stays there for 3 to 4 months. And progesterone is also the same. Progesterone can be given in a pill, a cream. It cannot be given in a pellet. And a testosterone can be given sublingual or topical or in a pellet.
Coming back around to a woman who she's not sleeping, she's horrified by her weight gain, and she's got the hot flashes, she's got the whole gamut, and she's been to the doctor that says, well, you just need to eat less and move more, and oh, well, take something to sleep or work out before you go to bed so you're tired and all of that. We all know about the importance of natural health lifestyle, taking care of the food that we put in our body and exercise. But then versus the hormones, which what I'm hearing from you, I've heard from the other providers, is that it's a balance. Where does a woman begin?
So in order to test hormones, there's several different ways to test hormones. I used to specifically do saliva testing because I did a lot of research on that. The only issue with saliva testing was, number one, a lot of women would come to me with blood tests. So with the blood test, it was very hard for me to compare apples and oranges. So it was hard for me to compare lab work with saliva. The other big issue with saliva is I don't know if have either of you ever seen a saliva kit?
I think I did one for cortisol. Actually, I did one for
Okay.
cortisol.
Yes. So a big complaint when you go through menopause is you have a dry mouth.
Oh, yeah.
Well, imagine I'm giving you a big kit and saying you have to spit in all of these 4 containers certain times of the day. So I realized not everybody can do it. And then I question the efficacy of those tests because some of them would say, did you even get enough? So now I specifically do blood work. And I always tell patients that I'm very transparent with patients. Your PCP or your OBGYN may say, I'm not going to order that because they don't know how to code it properly. So I could order a test on whether you're an elephant. If I code it properly, your insurance will pay for it. So I always say, I know how to code, so I always code it properly. And I'll test for more things besides just your hormones. So I'll test for all the 3 hormones that I mentioned, your cortisol, something called DHEA, which is a precursor to your hormones. Also, a full thyroid test, a full anemia test. So it's a more intensive test because you may find, but she's complaining of all these things, but you know what, her thyroid is underactive. So you need somebody who's going to just order all of that. And because if you just get one piece, there's only a small piece of the puzzle. I need the whole puzzle. The symptoms are the most important to me, and then also blood work. The blood work will tell me, is there a possible other issue? Because I have picked up other things on people that I said, this is more important. We have to address this first. And that is one difference that I will caution women about going to clinics. I always tell people if you're going to go to a hormone clinic, you need to ask the person who's treating you, what is their background? What kind of training have they gone through? How have they come to this? Do they have a medical director? Because I do feel that a lot of people will see an ad or a billboard and they'll go and then they'll be charged a lot of money, which is not necessary. And number 2, sometimes there'll be things on the blood work that is wrong, but the person that sold them this hormone package doesn't even know how to read it. My feeling is whoever orders any kind of test for you, whether it be a test, an x-ray, a mammogram, a bone density, they should be able to read it. And a lot of women, as they get older, we can all develop osteopenia. So that's another thing I tell women. You have to worry about your bones also. So hormones are not just for your hot flashes, your sleep, your libido. They're very good for your bones. And there are a lot of medications out there to treat osteopenia, but there are a lot of side effects to those medications. So just going back to that person that said for me to give everybody Ambien and Lexapro, the same thing when I have a patient with osteopenia, I'm like, why are we giving them a bone medication when the real issue is possibly lack of hormones?
Well, it sounds really complicated as far as balancing everything and looking at the whole picture because there could be other things that affect other than just your hormones, especially with different ages. And yeah, so it's really important to find a care provider, like you said, that understands how to read and look at that whole picture. So a lot of women come in and they will talk about weight management. And I'm going to shift a little the conversation towards that because we had talked previously, and this was really interesting to me, some of the treatments for managing weight. Can you share some of that conversation with us?
Well, going back to hormone therapy, I always tell people you don't have to go on it, but that's an option for you. And when I see a lot of women, I'll see all their symptoms, but I'll say, what is the one that is really bothering you today? Let's start there. And I would say that a lot of women, they're very upset about the weight gain. They have always been somebody who's always eaten healthy. They've always exercised. And it's not that they want to lose a ton of weight just to be thin. They want to feel better. They want to take the weight off because now their blood pressure is a little bit elevated. Their cholesterol is climbing. So it's just like those male physicians I talked about that were like, oh, it's all in your head. It's like the tire around my waist is not in my head. And it's very frustrating. So, of course, like all of us do, I do go with women through what are you eating? Make sure you're not drinking the wine. Let's look at the carbs. I really encourage exercise for your mental health. You know, I always say you can go run 20 miles. It doesn't mean you're going to lose weight, but it's good for your mental health. So when I was in private practice with other physicians, we did have a weight loss program. That program did use phentermine and phentermine, which is a stimulant. I really wasn't happy with that, but women did lose weight with that. So that is one option. There's some other medications you can use, something called Contrave, other medications out there, but they're basically stimulants. So I want to say within the last 3 years, I have been using a medication called a GLP-1 to help women use for weight loss. GLP-1s are in the news a lot nowadays. So a GLP-1, and it's actually taken from an enzyme from a Gila monster. That's like a fun fact, Jeopardy fact. So these medications have actually been out for a very long time. And they actually came out initially in just a pill form. And then they made an injectable. These injectable GLP-1s were made for people with type 2 diabetes. It is not insulin, it's for type 2 diabetes. And the reason I say that is the majority of America, the world, we're all on the verge of being a type 2 diabetic because of our diet. So these GLP-1s were very good at reducing the blood sugar of diabetics. The one nice side effect of this injectable medication, as we increased the dose, people lost weight. So the brand names of these GLP-1s are Mounjaro, Ozempic, and there's another one also, I forget the name, Trigelli or something like that. So those are the brand names of those drugs. During COVID, they did some research and realized, wow, people are losing weight. Let's change the name of the drug. Ozempic is Wegovy. Mounjaro, they changed it to something else. Anyway, when the drug company did that, they really ruined it for everybody. Meaning I used to be able to get that covered for my type 2 diabetics, and it reduced their glucose level and something called an A1C. An A1C is your blood sugar level for 3 months. So even people who do qualify for this drug, meaning they're type 2 diabetic, they're having a very hard time getting it. But going back to a specialized pharmacy that can compound it, if Marty, Robin, and I had the compound for ibuprofen, if we had that molecule in our possession, we can make ibuprofen. So these pharmacies, special pharmacies, I caution people, because I hear about people ordering it online from I don't know where. I caution you against that because we're not sure. But a compounding pharmacy, as I mentioned earlier, they are regulated by the National Pharmaceutical Company. They have to have special equipment to make these. So these GLP-1s are called peptides. So this is a once a week injectable medication. Truth be told, I tried it out on my husband first, as he is my guinea pig, and I tried it myself. And how these medications work, it tells your brain that you are not hungry. So whatever your trigger is, it turns off that little chip inside your head that says, I want to drink, I want to smoke, I want to eat bad things. So I've been prescribing that for 3 years as a weight loss medication. And I am just astounded about how well it works, that a lot of women will come in so frustrated with their weight. So the conversation will change from, I'm here to talk about my hormones, but let's talk about weight. So we kind of do both. And I said, let's focus on one. And sometimes just getting the weight off, because if you crave that alcohol, that's inflammatory also. So red wine will give you more hot flashes. Or if you're tired, if you're not sleeping at night, you crave carbs because you're tired. You're like, I just want comfort food. Carbs will give you more hot flashes. So some people alone are seeing improvement with things like hot flashes by just using a GLP-1.
I have a question about that, going back to earlier in our conversation, when you talk about the loss of estrogen, then contributing to inflammation, contributing to the adipose fat creation. Do the peptides also counter that, or would they still be benefited by going on estrogen replacement in addition to, or did the peptides just kind of, that solves the problem?
The peptides definitely can help with inflammation because, like I said, this was first geared towards the diabetic drug. But now every day they're publishing a new paper about how it actually improves your cardiovascular system. They're doing a new study now about how it's improving with memory loss and dementia. Because in general, processed sugar is bad for our body, it's bad for our brain. So every day they're coming out with new things saying it's helping with that. And the other thing is by reducing insulin levels and your glucose levels, that reduces the adipose tissue and that belly fat. Okay. So that's how it works. And once again, it's not a drug for people who are type 1 diabetics. That is a genetic thing. So the only contraindication to this medication are people who have type 1 diabetes or people who have a history of medullary thyroid cancer, which is less than 0.05% of the population. Let's go back to that physician who said you need to exercise before you go to bed. Well, if you're tired, you're not going to exercise. One thing I found with this medication, it doesn't make you tired. I have a recent patient. She's been on this GLP-1 injection for, I want to say, a month, and she's lost 12 pounds. And she came back because now I have her blood work back. Now we're addressing the hormone therapy. Some people will say, what if I want to do something naturally? You can try berberine. You can try inositol, which are both vitamins that can help regulate your glucose too. So whatever you do, you still have to take care of yourself, whether it's walking or yoga or Pilates or anything like that. GLP-1 helps with inflammation, helps with weight loss, can help with hot flashes, all that. It's not going to help with your bones. You're having a meltdown at work. It's not going to help with that.
Right.
It can make you feel better because you have more energy. And if you make someone feel better, they do better.
But what do you say to the naysayers out there that are saying, if you're not type 2 diabetic, you're taking the medication that you don't need and you're taking it out of the hands of people who really actually need it?
I would say it's not you, it's insurance companies.
Mm-hmm.
They had a medication years ago, it's still used, it's called Wellbutrin.
Mm-hmm.
So some people were able to use Wellbutrin to stop smoking. So the pharmaceutical company changed the name to Zyban. I never got a Zyban prescription covered. I got a Wellbutrin prescriptions covered. I never use a diagnosis of smoking because they'll never cover it. So I would say it's more your insurance company that's doing it for you because, I have patients that come to me from all over. And I'll give you a perfect example. I had a person that came to me that wanted the medication. She said, I have good insurance. I said, they're not going to pay for it. And I'm very transparent with patients. I do not charge astronomical prices for it. My prices are very reasonable. Patients will say to me, someone down the street charges twice as much. I said, well, good for them. I'm not the type of person, but so Ozempic, which the name of the weight loss drug that was changed to Wegovy. This patient I had that insisted her insurance would cover. I said, no, she went to the pharmacy and it was $1,500. Mm-hmm. And she bought it. And I said, oh my, I can't believe you did that. And then, I told her, I said, no, we can get it compounded. So one thing is insurance companies, which I'm sure, unfortunately, if you have a family member who's gone through a health crisis, you will find out very quickly. An insurance company's job is to deny. So they just don't want to pay for it. Just like in the beginning, gastric bypass, a lot of insurance companies will pay for gastric bypass years ago. They don't want to pay for it again unless you have specific insurance companies. You're not taking this medication out of type 2 diabetics. If a type 2 diabetic puts their mind to it, we're comparing a patient of mine, let's say a 52-year-old woman who's going through menopause, who's put on about 20 pounds. Then I have a male patient who's 300 pounds. I don't say to people, lose weight. I say, this is what I want you to do. I want you to download the app, MyFitnessPal or Calorie King. And you're going to put in there every day what you eat. And you're going to find out by 3 o'clock you eat too much and you don't exercise. So you're not taking anything from them. Everybody has the power to make that change. Mm-hmm. That particular patient is not making the decision to change. And whether he has to go to counseling or whatever, because eating can be an addiction. So people need to understand you're not taking anything out of someone's hands. The other thing is, even if you did have good insurance and you qualified if you're a type 2 diabetic, your primary care provider has to write so many pre-authorizations to say, you have this, and you have this, and you have this. They don't have the time, the staff, or the energy to keep faxing your insurance company to try and get it covered. They're not going to tell you that, but that's the truth.
When we're hearing like, well, my doctor says because all the people want to lose weight are taking it from, you can't have it. That's not necessarily.
No, if you're taking it as a weight loss medication, your insurance company is not paying for it.
Right.
And the other issue is even my patients who had very good insurance, in the beginning, they got those medications covered. Now the insurance companies are pulling all their labs and saying, well, they're better. Take them off.
So it's like more, so it's not a question that there's like a shortage of the medication out there. It's just the reluctance or the unwillingness of the insurance companies to pay for it. But someone, whether they're a type 2 diabetic or they're wanting to avoid becoming one by releasing weight, it's out there. They just have to be willing to find someone that they don't have to worry about running it through insurance. They can pay for it out of pocket.
Out of pocket. And like I said, there's really no contraindications to the medication. And there are people like myself, I get it from a compounding pharmacy that I vetted myself. I've used them actually forever for hormone therapy. So I'm very familiar with them. And that's one thing, just like with hormones or anything, whether you're dealing with any kind of medical issue, you want to go to someone that you trust, that they seem to know what they're doing. They're not trying to just sell you a product.
Is there kind of like a ballpark of what someone, let's say they are paying out of pocket, that's reasonable? Like you said that you had that patient that paid $1,500. That's obviously, wow, that's astronomical. But what is more of a reasonable kind of range?
So the GLP-1s, you have to give yourself a weekly injection. But I mean, the needle is like the size of a hair. It's very easy. I only have one patient who refuses to inject herself, but it's very easy. So some people will give you pre-filled syringes and you just take those home. But I'm a busy person. I know that people have busy lives. I give them a vial of the medication. I just send the vial to their house. I'm in Palm Beach County, Florida. So they're very wealthy in this area. So I want to say a vial. So it's like a vial that would last you probably 6 to 8 weeks, can go anywhere from $300 to $600. Now, wow. And we all get it from the same pharmacy.
Yeah.
We're just upcharging you more.
Good to know.
Well, that's interesting because that kind of ties back around to number one, being informed. Number two, having a care provider that understands these intricacies of, what the prescription is, how much it is, where is it coming from, why are the insurance companies charging so much? And just like you were explaining about the changes in the name can mean the difference on whether the insurance company will pay for it, not pay for it. And a lot of people can get lost in all that information. And so it's important to understand how to find a care provider like yourself that can paint that picture for you, help you to understand it, and help you to make good decisions for your health.
Healthcare is a business. I tell people when you go to different countries, there's not a billboard on every corner. We've got the top hospital. It's not there. So we actually need to be better at prevention. When I treat somebody, I always have their budget in mind. I will have women that will go to their OBGYN. They say they have vaginal dryness. They're given a prescription. They go to the pharmacy and have a heart attack. Even in the ER, if I had a woman with like urinary tract infection, I would say, you've been here several times for that. Do you have atrophic vaginitis? What? You should be getting estrogen, all this stuff. And I would like real little notes for these women. And the people I work with will be like, you're crazy. She's here for a UTI. Just treat her. So if someone just gives you a prescription, sometimes you can't afford it. And then we as providers always think, well, they're not compliant. No, we didn't make sure that we gave them something they could afford. So that's the other thing. I tell people use GoodRx. You don't use your insurance if you don't have to. Amazon, believe it or not, has their own pharmacy. Sometimes that's cheaper. And then, a long time ago, there was an estrogen cream that was pharmaceutical that people would ask me, do you not like that? I'm like, I love it, but I'm not going to write you a $200 prescription. When I can get you a compound and one for 30, it's the same thing. Why would I do that? So, you also need to find somebody that knows what you need, knows what you can afford, because like I always said, I don't assume that when people come back that they didn't take it because they didn't feel like it. I think, well, maybe they couldn't afford it. So that's another thing to keep in mind.
Well, I appreciate you saying that. Something happened to me was recently, the thyroid medication that I take, and I go through GoodRx. It was costing me like $250 for 90 days. And I talked to my doctor and he's like, I'm going to make you so happy. And now I got my 90-day supply for like $60 for 90 days. And I was like, I wanted to cry and I wanted to give him a hug. I'm like, I love you. I've been for years just thinking, well, this is how much it is. And he's like, no. I've got this compounding pharmacy down in, here. And it's amazing. It's the same. It helps so much. Real quick, just a couple more questions about the injectables before we move on. I've been seeing concerns people have is one, that they have to stay on it for life. And then two is the fears about things like side effects like stomach paralysis. You mind sharing what your thoughts are on that?
So for certain people, food is an addiction. So if you're addicted to food, I always tell people that I can give you a medication to stop drinking. I can give you a medication to stop opioids. I can give you medications for a lot of things. There's such a stigma, like I said, with the weight loss, like, oh, you're not doing enough. And I look at it like if someone is addicted to foods, for instance, people who have gastric bypass, a lot of their studies are now saying they have to stay on it for the rest of their life because they are missing that little switch that says, you've had enough, you're not hungry anymore. I guess Oprah did a special on it and how she used to, I think she bought into Weight Watchers. And Weight Watchers, by the way, they're advertising, we can give you a Wegovy for $1,500. Yeah. So she admitted that she always thought about food. She was a food addict, just like people are gamblers or smokers or drinkers or, shoppers, whatever your addiction is. If you don't have the tools or you're just struggling, it's not harmful to stay on it for long-term use. It's not harmful. Now, the stomach paralysis, so they are recommending if you're going to have a surgery, you need to stop it for a week because it does kind of slow down your GI motility. So meaning you could have some food still in your stomach if you were, let's say, having like a major surgery. I mean, not to get into detail, but if they intubate you and you have a slow GI motility, they're worried that you could aspirate some of the food in your stomach. There's also been some people who have complained about, constipation. I have a patient today I spoke with that she actually has irritable bowel syndrome. So she's always had that problem. So before I even started her on the medication, we talked about that. What are you going to do? How are you going to prevent that? You're going to drink plenty of water. You're going to take your calcium, all of that. So there are things that you can do to offset those side effects. And just like I talked about before, how all of us, if we go into that research and we're in the study and we say, oh, I got an infected toenail, even any medication that I've given a patient. Years ago, I gave a patient a diabetes drug, and I read online it causes liver cancer and pancreatic cancer. And I'm like, no. The fact that you went 20 years with a high blood sugar and never dealt with it, that's your risk factor. So when things are coming out, they're saying you could this and that, and that. I have not personally seen it. I have an acquaintance that said that she had some bowel issues with it. So she stopped using it. But other than that, because like I said, even though the weight loss drug has technically been using it for only a couple of years, the GLP-1s have been out for a very long time, 8 to 10 years. So we would have been seeing it with that.
This has been such amazing information. It feels like finding the perfect healthcare professional that has the whole picture, that has your back, that's willing to listen to you, that's willing to hear what you have to say and validate your real thoughts and symptoms, and actually work with you on a plan of action to move you through your menopause symptoms, give you good, solid information, and give you good, solid plan. That sounds like where you're coming from. And I just feel like anybody that works with you is going to get the best quality care from a provider possible. You're just a rock star out there. I'm just so glad that you're able to share some of these things, because many of the topics that we talked about, I would have never thought about, talking to my care provider about them, but they are things that we need to be aware of, and we need to educate ourselves as women so that we know if we are talking to a good care provider that is giving us good information, or if we're just giving a care provider that's just giving us a magic pill because they need to go on and see the next patient. So I really appreciate you sharing this, and I really hope this helps our viewers to think clearly, educate themselves, find those good providers out there that are going to give them the best plan for their health.
Christine, do you only work with patients in Florida, or are you able to work with women around the country?
So I do a lot of telemed, and only because being in Florida, I have patients that go north for the summertime. A lot of them are leaving now, or I've had patients that, moved away. I think my furthest patient is Hawaii. She actually comes in to see me once a year. But I do a lot of telemed because even I've actually had a lot of patients that have gone to naturopaths. As encouraging women, you should get hormone therapy, but the naturopath can't write the prescription. So that's another thing. Women may, and for some reason, it's more, I would even say like remote areas, they found a naturopath, but they can't find somebody to write their hormone therapy. So I do a lot of things by telemed. Some states are limited as to what I can send. Like, for instance, I have some patients in North Carolina that North Carolina is a state that is restricted. I can't send that GLP-1 medication to. Or if I have women who are on testosterone, testosterone is actually a controlled substance. So right now, the laws change a little bit. And in COVID did open a lot of things, so more of us can do telemed all over, but testosterone is one thing. So I actually have patients all over. They come to me by referrals. And even if I have a woman that she wants to see somebody in person, sometimes I'll meet with them and I'll say, no, I know you want somebody in person. I'm on, big chat groups, and I'll put in that chat group, hey, I have a patient in Missouri. She really wants to see somebody in Missouri. Who's there? And these aren't just random providers. It's providers who have the same mindset. So I always tell patients too that even if I can't help you, I try to find you someone, or direct you to somebody. And that's one thing. I have bad news is that a lot of the good providers don't take insurance. So I always tell people, if you have a remote HMO, the likelihood that someone's going to sit down and talk to you for a while is very unlikely. So there are providers like myself. Like I said, my fees are not astronomical. I don't try to gouge people. I try to stay away from the clinic if you can. I'm not saying they're bad, but you may, be charged a lot there. So I really encourage women to, like, even if, let's say if you move to your area and you're new, don't go in the phone book, don't look at Google reviews, join a women's group. Join a women's group. In your age, Menowave is great, but it's a lot of women in different parts of the world. So even I tell people, join a book club. If you can't find like a women's group or a meetup or whatever, neighbors, co-workers, but really get some advice from people who are already on these medications and are successful. And that's where you'll find your providers.
So true. So true. And that's your local community, and they're going to know the local providers and be able to their experiences. That is invaluable information right there.
Christine, how do people find you? If someone wanted to reach out to you and maybe work with you or get a referral for someone in their area.
My website is healthylivingmedicalclinic.com, and I practice in Jupiter, Florida. So I'm actually on the Menowave page as a listed provider. And my information is on there.
That's awesome. Well, I hope a lot of women reach out to you because this has been so informative today. We're truly blessed to have you here. Please reach out to Christine and get in touch with her, talk with her, ask her questions. She is such a wealth of information. As well as both Marty and I, we do mindset work, helping you to create a healthy, balanced lifestyle. And that includes coming in and balancing out not only the physical, but the emotional piece, because they're all connected. And Marty is a phenomenal hypnotherapist. And she also, well, Marty, why don't you just tell them?
Well, thank you, Robin. Yes, like with Robin, I specialize in stress relief, mindset shifts. But what I also do if someone is struggling with, like you said, Christine, bad habits and addictions like smoking, hypnosis is an excellent tool for overcoming that, which I do, as well as I actually published a book about 10 years ago on self-hypnosis exercises for shifting your mindset to be able to have better habits as far as sticking to your weight loss program, whatever it might be. I always say, if I could have you come into my office and go to sleep for 2 hours and wake up 20 pounds lighter, I'd be the first in line for that. However, things like sugar addiction and the emotional connection to the joy of what food brings, I actually have a whole book that I wrote on self-hypnosis exercises on how to overcome that and walk yourself through it. It's out on Amazon. It's called Thin Sights, a 30-day journey to mind and body transformation. And finally, before we go, what I am excited excited to announce that I'm launching is a weekly mind massage. It's a group hypnosis session for whoever wants to join to experience. I actually take you through a hypnosis process to guide your mind and body into total and complete relaxation and give you suggestions to help make this journey just a little bit easier. If you're in the Menopause support group on Facebook, you can just message me. I'm going to be posting events in the group as well, or you can reach me through email, marty@martydaily.com for more information.
Well, that's awesome. Thank you. Thank you so much for sharing that, Marty. And thank you, Christine, for being on our podcast. We have so enjoyed you. If you like this, like and smash that subscribe button, and you'll be able to see much more of all the wonderful expert ladies that we have every week on our show. This has just been such an incredible journey, and we're just so grateful to be here. Well, thank you all for joining us at the Menowave Lounge, hot flashes and cool conversations.
Thank you, ladies. Goodbye.
Bye.
Thank you for joining us in the Menowave Lounge. If you'd like to connect with Marty, Robin, our guests, or any of our expert Menowave care providers for personalized advice and support, head on over to our website at menowave.org and fill out an assessment that will match you with a provider who knows just how to help. Remember, you don't have to face menopause alone. Our team is here to provide the guidance and care you deserve. So, take that step towards reclaiming your well-being and connect with a Menowave care provider today. Thank you again for tuning in, and we'll catch you on the next episode of the Menowave Lounge, hot flashes and cool conversations.